Got it. Well, welcome to another VO Weekly, Venture Outfitter Weekly, sponsored by Tech Ranch. This is our program for working with entrepreneurs, and we've got entrepreneurs around the world that have joined us today. It's pretty exciting. We're going to be talking about reforming healthcare. One of the purposes of the Venture Outfitter is to help entrepreneurs take on together markets that have been somewhat problematic or intractable. The typical entrepreneurs that we work with around Tech Ranch are driven by vision and values. And the exciting thing about this concept is we believe that schools of entrepreneurs and startups can actually take on existing markets and improve them. And we're going to talk about that. I'm actually going to make sure that we talk a little bit more today about how we organize together so that we can have this type of output. Now, one of the things that we said in the show notes is healthcare is bad business. According to the World Bank, the United States healthcare expenditures per capita is over $10,000 a year. According to the World Health Organization's ranking of the world healthcare systems, the U.S. comes in 37th place, just below Costa Rica, which has a per capita expenditure of $900. And just above Slovenia. France, which comes in first place on the same ranking, spends less than half what the U.S. spends on healthcare, around $4,600 a year. There's a lot of other details that could be said about this, and the important thing that I want to make sure I say is part of the value of having what I see right now, healthcare professionals that are here from Nigeria, from Mexico, from Honduras, we've got more Mexico, we've got Romania, we've got an individual from Ireland. The thing that's interesting about this is to say, I'm not saying that France is better or worse or stuff like that. And I want to talk about that concept, but I do want to make sure that we investigate in some things around this. First off, thank you to our sponsor, Linda Blackman, who was in Venture Force 17, runs the co-working space DualWorks, here in Austin, where Tech Ranch has its formal address. We work with 4 different co-working locations in Austin and happy to have our headquarters at DualWorks. If you're looking for co-working or if you're outside of the country and you need a physical point of presence, they have some really awesome deals support. They know that we work with international entrepreneurs. And so part of the idea about this is making sure that there's solutions for you if you need that physical point of presence. You don't have to even be at the $200 a month co-working to have that physical point of presence. And like I said, we have entrepreneurs around the world that leverage the space. But if you're here, come and see us. And today there is a Thanksgiving party. So right after this, I'm going to be racing out to make sure I get some of the pumpkin pie before it's all gone, because I'll be in Hungary next week celebrating with a handful of other Americans in Hungary, American Thanksgiving. So, but come on over to DualWorks and they'll take care of you. We have a handful of you that are involved in the VO community, the Venture Outfitter community. That's where you can actually be a part of this program and be involved in the online community. But the thing that I want to make sure I'm driving towards, and we have 2 new additions to the VO network this week, is to get into the Venture Outfitter network, which has some special offers. It has, it's like you get access to our Venture Essential program. Since we have 2 new teams that are coming in from outside of the US, there's some specific things that we'll do for you on helping you with US market entry as well. And we'll be going into that a little bit more. I'll be working with those entrepreneurs myself directly as part of what we're doing as we're onboarding a lot of entrepreneurs into the VO network, or I guess I should say startups and scale-ups into the VO network. In fact, this next week, I will be physically in Budapest, Hungary. And while I'm there, part of the whole idea is to working with the Hungarian government to have a number of those companies step in. And we'll be doing some specific activities for US market entry. Now, the VO network is not just for that, but that's one of the things that naturally happens. And so we'll talk more about that. But I'd like to just take a second and have Catalin Brăciu from Romania. He lives in Cluj, Romania. Say something, just like introduce himself really quick. And David Nichols of Core Technologies, which is out of Prague, the Czech Republic, say something. Both of them were in Austin this week and decided to join the VO network. Catalin, why don't you start, since I can see you first? Just give us like a quick introduction to who you are, what you're up to, and anything else you'd like to share with us.
Yeah, of course. First, thanks for inviting me to this network. It seems like it's a really good pack of people. So who am I? I'm Catalin. I'm from Romania. I run a software development company, Linify, and we are focused on the health and education industries. And we also have an internal R&D project that aims at preventing burnout in organizations. What we do at Linify is we help bold innovators build successful and scalable products through a validation-driven process. That's something that we do different from most of our competitors. The fact that we put really high value on validating each step of the process together with our partners or clients. And as a personal thing of mine, I've been doing intermittent fasting, taking a cold shower, and meditating daily for the past 5 to 6 years.
Excellent, excellent. Well, and very focused on wellness. The thing that is really interesting about this project, I asked Catalin on one of his future times, we're going to actually talk more about that wellness project that they have as a research project inside Linify, because it's quite interesting about how they're calculating on real-time flow states for individual entrepreneurs. So thank you for joining us. Let's switch over to David Nichols. David from Core Technologies in Prague, Czech Republic, or Czechia.
Yeah, thanks, Kevin. Thanks for having me. So my name is David Nichols. I'm the CEO of Core Technologies, based out of Prague. I'm actually originally from Texas, so I was visiting Austin, where I went to school 30 years ago. Yeah, so we have a platform that's basically an enterprise service bus. Our strategy is basically to partner with AI and data science companies. So if you have an AI or data science solution and you want to scale in enterprises, we solve the problems of like getting you access to data, fault tolerant process automation driven by, for example, insights or generated by the analytics, and also scalability and things like that.
Perfect, David. Thank you for being here. We'll certainly be helping David's company get connected into the. There's a lot of AI machine learning companies here, and big data. Being able to connect to those big data sources is important. So thank you for joining us. So let's hop right in. Today, I want to set a context. I want to set a context for the discussion we're about to have, or actually, I really want it to be dialogue. What is this whole idea about debate, discussion, or dialogue? Well, we've seen a lot of this sort of stuff happening in our politics, where one position is arguing against another position, and they stand there and they just fight against each other, back and forth, back and forth, back and forth. Things start moving sometimes to more discussion type of interaction, where actually people are kind of getting to a sense of really what might be there. But the thing that I want to promote in our network is dialogue. What is dialogue? Dialogue is this idea that we actually really, I don't give up my position, you don't give up your position, but we really try to dig in and understand at a deeper level how we might be able to work with each other, and then how we might change something together. Like I think the thing that I was actually trying to say a few slides ago about the healthcare market, I think it's really clear to see, based on some of the outcomes that we see in other parts of the world, that healthcare, I believe, in the United States is broken, right? I think it's broken. Now it's amazing what people can, what doctors can do here and things like that. But still, I don't think we're getting our money's worth. So I'm not saying spend more money or not, right? That's a position that I think a lot of people in the United States could actually get behind, and saying, hey, it's broken at some level. I don't think anyone would fight for exactly the system that we have. Doesn't mean that we need to spend more money or not, right? So in a dialogue point, I would make that point, and try, I think there's a lot of different points that other people would actually line up around. What I want to promote in our discussions, as we have like I've been using this metaphor of the school of piranha, that is a bunch of startups and scale-ups taking on existing marketplaces, organizing around certain value chains, that, that we recognize need to be changed, especially since I come from a disruptive innovation past, right? That is my past. I, have been a part of disrupting six different markets during my career. But the thing that I think, as we look at having the school of prana, that is your companies working together, if we enter into dialogue, we can do things that you wouldn't be able to do with just debate back and forth. So perhaps on this program today and other programs in the future, we'll have some debate type of things that happen because it just happens. But the thing that we really want to drive towards is dialogue, because really debate protects the status quo, whereas dialogue looks for a solution and lines up people together, right? It's, you and I don't have to fully agree to something. And I'm an entrepreneur, you're an entrepreneur. I'm not working for you, you're not working for me, but there is a place that we can collaborate. Maybe we compete a little bit too, but there's a place that we collaborate. And through that collaboration, through that dialogue, we can actually produce a better result than what we have right now. I personally would like to see 10 times the healthcare for 1/10 the price. And I actually believe, as a technologist that believes in the market, that's a real possibility. But we have to enter into dialogue versus debate about it to actually get someplace. That's one of the premises I want to lay down at the very start of this discussion, or dialogue, I should say, and to try to explore together. So today we're going to talk about reforming healthcare in the Venture Outfitter Weekly, and we're going to start. We have two speakers, and then I know that I can already see from the screen we have quite a few other individuals around the world that come from a healthcare background. Some of you that are actually actively entering the U.S. market. Some of you that are, doing other things that might be related. Some of you that are actually in fully different markets. Totally understood. But part of what I want to do is introduce two of my friends. Both the speakers are friends. I've joked with both of them that they're both drinking buddies. With Lauren and her husband, I've drank a lot of wine. With Randall and his wife, I've drank a lot of tequila. But that being said, to be a little bit informal, but also to actually speak seriously about their backgrounds. Lauren's a health policy consultant in Austin. She specializes on writing about healthcare policy. She's got a couple of different books out. And every once in a while, we'll hear her in the community around Tech Ranch saying, hey, this is perspective that if you haven't done all of this different research, you might be interested in knowing about. And so what I had said to her, she's like, hey, Kevin, what part of this do you want me to tell you about? And I'm like, Lauren, you're the expert. Tell us what we need to know about the following thing. Lauren, thank you for being here today. I appreciate your insight, and I appreciate your patience as well in the support that you've given to Tech Ranch entrepreneurs over the years. Let me hand it off to you so that you can step in and take over and kind of give us a perspective from your background.
Sure.
Thank you for being here.
You're welcome. Let me pull up my slides real quick. All right, can y'all see that?
Yeah, your slides are coming up right now. Perfect.
Okay. All right. And pardon if I'm looking over here, I have two monitors, so I have my some notes up. So I want to give y'all an overview of healthcare reform in the U.S. and issues and potential solutions that I've been thinking about and studying for the past few years. And these are mostly based on the last chapter in my book. So if you could see, just blurring out with my background. So there's, in that chapter, I kind of wrap up a lot of kind of big issues and try to summarize things. And then this is one of the few things I've written sort of for general consumers and not like academic or healthcare people. So I've tried to simplify things, but as you know, this is just a complicated subject. So I have a lot to go over. I may talk kind of fast, and I don't know if we should save questions to the end, if it might be best, but
what we can do is if you have a question, go ahead and post it into the chat. I'd like to make sure we get to hear from our two speakers, and then we'll certainly have time for interaction, dialogue, and discussion on deeper questions. So yeah. Now, if there's really a burning question, we can step into it. I would actually like to, just for the sake of time, we'll try to do our best to to keep things, go through the material that y'all share so we can have future, deeper discussion in the future.
Okay. And I don't have the chat up. I see the number up there, but let me know if there's something I need to, something whenever that I need to address. And first of all, I want to say real quick, I come from a policy background and not a business background. So like all of you, but hopefully there's something that'll at least make you think about things differently or spur some dialogue or whatever. So, all right. So first, some brief background. I won't read it all, but there's been a lot of big changes in the past few decades. Healthcare is always changing. And I just want to set the stage for rising costs a little bit. Costs are still rising for healthcare and health insurance, and many people are left out. And the U.S. healthcare system is incredibly complex, and there isn't even one system like maybe in other countries. It's really just a mix of public and private healthcare programs, insurance plans, and providers at federal, state, and local level. And the cost of this combined system was $3.8 trillion in 2019, which was 17.7% of the U.S. GDP. And to compare, which is interesting, healthcare was just 6.9% of the GDP in 1970. So everything has gone up, but healthcare has gone up a lot more. And there's a few more stats there at the end. I won't necessarily read them all, but about prices going up, such as hospitals going up 42% in the 1 7-year period that a study looked at. Insurance went up even more. So kind of set the stage. And here's just some general reasons I pulled together of why healthcare costs are so high in the US, and there's a bunch of different reasons. New medical innovations. So again, these aren't necessarily all bad things, they're just reasons that prices are so high here. Chronic diseases, which are expensive, high administrative costs, the, I should say for-profit, not for-profit, nature of the healthcare system, high prices for pharmaceuticals, hospitalization, and most other healthcare services, unnecessary or duplicative tests, medical malpractice claims, and defensive medicine, which we'll talk about a little bit more in a second, and fraud and waste. And just a couple of studies I found that were interesting when people are trying to really examine what part of the healthcare system is growing the most in cost. Study in JAMA that looked at the dramatic rise in costs showed they looked at 5 main factors: population aging, growth, diseases, how much healthcare was used, and the price and intensity of healthcare provided. And the results showed that price and intensity counted for the largest percent of these 5 factors at over half of the spending increase. So when people may say, oh, it's just we have more people or an aging population, it's really, those weren't a big part of the price increase. And one more study looked at a variety of causes of waste in the healthcare system, like avoidable complications, unneeded tests, things like that. And the results are kind of depressing. 25%, they found that 25% of all healthcare spending, 760 to 935 billion a year, was on wasteful things. And administrative complexity was the largest single source of the waste at about 1/3 of the total. So we all know, just personally, if we've tried to figure out our insurance, get a prior authorization for something, any of that, it's just very complex from the consumer's point of view, hospital point of view, everybody. That's just how our system is developed. And I've kind of put together, whenever I try to lay out pros and cons, it seems like there's a lot of contradictions or dichotomies. It's like, and a change in one affects the other. And I've just kind of grouped them into just 5 main things here. Some, I'm sure this isn't all of them. These are just some kind of general things to talk about. Whoops. The first is that, as we all know, healthcare is big business, and systems expensive because, most entities are out to make a profit. So, for example, let's see, I have a few examples. And kind of the dichotomy there is that businesses need to make a profit and take care of their investors if they're, public companies, but or any company, but also profits and competition foster innovations and improvements that help people. So, you know, profits aren't all bad, but it can get excessive in the healthcare system. And for example, the US doesn't regulate pharmaceutical prices like many other countries do. So the prices here are the most expensive in the world. But also US companies perform the most pharmaceutical research and invent the most new drugs. And also with health insurance, obviously some dichotomies there or tensions, because health insurance companies help people access care and get care they need or couldn't otherwise afford. But there's also competing priorities, and they're incentivized to pay out less in medical claims in order to increase their profits for their shareholders or investors and things. So, and also to pay for administration. The Affordable Care Act of 2010, that some people know as Obamacare, that was the biggest probably piece of healthcare legislation since 1965 when Medicare and Medicaid started. So it had sweeping changes to a lot of different areas. A lot of it was for individual insurance, because there's now the marketplaces, healthcare.gov, that people, you know, some people know about. But another dichotomy there, some people think it went too far and some people think it didn't go far enough. It didn't make a public health plan available like some people wanted. It didn't totally change some areas, but it did change individual insurance a lot, and even small business insurance. It's treated more like individual insurance. They can't deny people for pre-existing conditions, a lot of things like that. So those are some issues. Let's see, next real quick, controlling costs. Whoops, I keep doing that on the wrong screen. And obviously, ever increasing costs are not sustainable for families or the government, but trying to control costs and cut down on services sometimes leads to people warning about rationing. But if you think about it, the healthcare system is already rationing right now, because, you know, there's people who can't get the care they need. If they can't afford it, they don't get it. There's whole, you know, classes of people that die earlier because they don't get health care. So really, our system already rations things. All right, two more of these kind of things I put together are the hidden and varying prices. That's a big issue here, because healthcare is not a normal market. Prices aren't apparent to consumers who need to buy services, especially beforehand. We've probably all run into this in our own life. It can be frustrating to just figure out what you're going to pay for and how much you're going to pay. And people point out that in no other instance would you buy something expensive without knowing the price. You wouldn't go in and buy a car without knowing, but you may go into a surgery having no idea how much you're going to pay, what you're responsible for, what the insurance company is going to pay, all that. And there have been some laws on this. There's some price transparency laws, but because our system's so convoluted, that runs into problems with proprietary negotiations between insurance and providers. So they're trying to get around those. I've noticed that hospital websites are posting prices like they're supposed to, but they're just general prices. They're not really what someone would pay with their own insurance. So it's still, or without insurance even sometimes. So it's still really hard to know. And the last thing is unnecessary tests and defensive medicine. Patients often receive duplicative or unnecessary tests and procedures, which drive up costs and even do harm. And some causes are not having adequate records of previous test results, and performing procedures that are shown not to be effective even. But also, I think I had an example of that. It's because one reason is just medical malpractice insurance is expensive, and it goes up for doctors and providers if they get sued. So I've even had doctor friends tell me, you know, we have to almost prescribe more tests, more things than we think we need, or if we know it won't do any good, because we need a paper trail that we've done everything we can in case something, you know, is wrong later, or we get sued because someone thinks we didn't do enough. So that just adds, you know, a lot, and it's hard to know what to do about it. You can't totally stop. You don't want to be the person who 1 in a million whose cancer wasn't caught because a doctor didn't think a test was necessary, but there's a lot of unnecessary ones that go on and just add to price and waste. And I'm not sure how other countries handle that. They don't have probably the malpractice issues we have here, but it's still a hard thing. And also some people even sort of blame patients and say that a lot of people expect a test or a prescription if they go to the doctor, and that's why doctors will even, hopefully less now than they used to, but prescribe antibiotics. If someone goes to the doctor with a cold, they want a prescription and they want their antibiotics, even though antibiotics, only work for bacteria, not viral infections like colds. So there's just a lot of waste on both sides.
So
those
it's all
are some of the.
Go ahead. I was going to just ask you specifically about this, like some of the ideas that you actually see for engaging in reforms, because I know that part of what you and Randall both are looking at is how to change the system in 2 different directions. Go right ahead, Lauren.
Yeah, I was going to say that just kind of sets up some of the issues, and then some reform ideas. I've just and again, I'm coming more from the policy and regulatory and academic side. I've had more experience in the business side, but I've just kind of pulled together there's kind of 2 main, what I call comprehensive reforms. And then the next slide will have lots of smaller things that have been done or that people have proposed. So for the comprehensive reforms, which probably won't happen in the US anytime soon, really, but these happen in other countries. The main way to reform the whole system is universal healthcare and or single payer healthcare. And they're not really the same, even though people sometimes use them interchangeably. Universal healthcare just means that everyone is covered, citizens and legal residents, as much as possible with some kind of insurance system. So most industrialized countries have universal healthcare, whether it's single payer or not, like Australia, Canada, France, Germany, Switzerland. And the advantage is that almost everyone's covered by health insurance, obviously. So it's easier to access healthcare services, and it's intended to be affordable for everyone. I don't know if it always is. And a disadvantage is if overall costs are higher than before, or government subsidies are needed to make the insurance affordable, that the government may need to raise taxes to cover that. And single payer healthcare just means there's only one insurer or payer, and almost always a federal government. And there's usually universal care along with that because the government's covering everybody. And it may be free in some places, or there may be deductibles and co-payments. And Medicare in the US is a single payer program, which is now for people 65 and older and people with disabilities. And some people that have called for more universal care here, or single payer care, I guess, have a thing they call Medicare for all, which means it would just be like our Medicare system, or we could even actually extend Medicare to everyone. So people want to do that piecemeal, and instead of 65, start covering people 60 and over, and then maybe 55 and over, and gradually extend it to everyone. That's one proposal. And I want to point out, this isn't the same as socialized medicine like in Great Britain, because the providers in Medicare here and most proposed single payer systems in the US would still be private. So we'd still have private hospitals, doctors, the whole system we have now. The government wouldn't own things like in Great Britain. So that's more socialized medicine. And the only place that happens here is with the military hospitals or VA, where the government actually employs the providers, but everyone else here is a private provider, whether the government's paying them through Medicaid or Medicare, or private insurance is paying them. And so advantages are greatly reduced administrative costs from redundant insurance functions, because obviously we have so many insurance companies now doing the same thing that there's a lot of redundancy that's adding to that administrative complexity, like that one study found. So it would decrease the need for providers to deal with so much paperwork, as they often complain about, and health insurance would no longer be tied to employment as it is for many people in the US. And that's a huge thing here too. The US is the only country that has that, where basically you change jobs and you get offered a different insurance if your job, offers that. So that's just something kind of weird and developed here, I think, after World War II, and it's a whole system. But if we didn't have that, people could feel, more free to change jobs. And the ACA helped people do that with individual insurance. You can get your own insurance, between jobs, or just have it if you're a small entrepreneur. And we have individual insurance through the marketplace. So it's much easier and better now than it used to be. But still, there's still that job. I think way more than half the people in the U.S. have a job, employment-based insurance.
When that's one of the things that I see a lot of times is the biggest block to entrepreneurs wanting to start startups here in the States is, they'll be like, they have a brilliant idea. They already have connections to the people in the market, but the healthcare ends up being the biggest block. Lauren, why don't we do this? Why don't we go ahead and we'll switch over to Randy, and then we're getting a lot of really great comments in the chat. And I'd like to actually start processing some of those, but I want to make sure that that we kind of get both of you all, everyone primed up for what your backgrounds are and your insight. I really appreciate your insight about that, because I think the thing that's interesting is, like, even the distinctions between socialized medicine, single payer, and universal healthcare. I didn't know those distinctions. Why don't we do this? Randall, if you're ready to roll, I'd like to go ahead and be able to share back over to you, and go ahead and do an introduction really quick, so that we can make sure that we have some interaction time with the chat during the time that we have together. Thank you for that, Lauren. That's really exciting. I mean, it's really interesting because of the perspective. Randy, so one of the reasons that I picked our speakers the way I did is, Lauren obviously has the depth of background about policy and what's happening there. Very thoughtful about the way she's in the books that she's written about, how we can examine that. Randy's coming in at a whole different other position, very, 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 very passionate about the free market. One of the things that he's, I don't know that he's officially a libertarian, but he's one of my friends that I count among my libertarian friends. And I have quite a few friends, because I've been an entrepreneur for such a long time, 30 plus years now, that, I lean that way. I'm not exactly that, but I'm not exactly Democrat, and I'm not Republican. But I like to have a lot of discussions with Randy about that. He's very passionate about the free market. He started a company called MI7 that's taking on the IT portion of some of the issues that we just heard about from Lauren. I want to get his perspective on this. He's been a long-term Austinite that has driven a lot of ventures around Austin, as well as built a lot of support organizations for ventures around Austin. Both Lauren and Randy have been long-term mentors, as well as supporters of the Tech Ranch. And so I also appreciate that. I want to say thanks to both of them from that standpoint as well. But Randy, why don't I pass this back to you and give us your perspective
on what?
Give us tell us a little bit of your background first and foremost, and how you're in the process of reforming healthcare in the US.
So rather than do some slides and stuff, I think it's easier, given that we do have a lot of questions here and we want to have a dialogue, for me to just kind of give you a quick overview. I'm an entrepreneur. I approach this as a business guy. That's what I am. I've been in technology for some time. Going on multiple decades. Our company, MI7, which is based here in Austin, we started this company about 5.5 years ago. We're actually focused in the trenches of healthcare. We like to say we are deep, 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 deep inside the bowels of healthcare IT. Our focus is healthcare IT. Inside of that, we are focused upon a problem that has been vexing this industry for 30 years. And those are the kind of problems that I, as an entrepreneur, like to build companies around, because I see market opportunity. And the specific area that we focus upon is known as interoperability. That's incorrectly stated within the healthcare industry, but that's because of the type of industry it is. It's truly data integration. And what we are focused upon is clinical data integration, which is pulling clinical data out of these data systems you see in the industry called EHRs or EMRs, electronic medical records. We pull the data out and push data back in. Solving that problem has been an ongoing issue within the industry for 30 years. It was an issue that has been solved every 2 years for the last 2 years and has been, or 30 years. It is completely solved. If you listen to the new head of the ONC, the Office of National Coordinator for Health Information in the United States, we've solved the problem. We have a new standard. That standard is now the 27th standard, promoted by 40 different organizations involved in data integration. I'm glad they're doing that. I'm very happy with that. I just happened to talk to one of the major EHR companies yesterday and was telling their CTO, I'm ecstatic that we have another new standard, because new standards mean that MI7 has another reason to go solve this problem for people, because the more standards there are, the better it is for us. The part that we play in, and where you'll hear me come from in answering and responding to any of your questions, is we see the big issue in healthcare as an access to the information and to the technology. And in all fairness and frankness, technology in healthcare sucks. It is very difficult to do. It is very difficult to break into. Most of the people that are involved in it are highly incompetent and massively overpaid. It is an industry that does not spend nearly enough money on IT while whining constantly about how much money they spend. So to give you an example, on average, across industries, companies spend about 8% of their revenue on IT. Forward-thinking industries, aggressive industries like finance, spend closer to 11, 12%. Healthcare is around 5%. So despite fancy carts and lots of laptops and lots of equipment inside of health facilities, the truth is we don't spend very much money on IT or technology to solve problems. And that's the issue. The issue is, how do you apply the technology to solve the problem? And there's a lot of reasons that's very, very difficult to do in this industry. It's a very highly regulated industry. There are new regulations every week coming out. Everybody's trying to follow the regulations. The regulations conflict with each other depending upon who's paying what where. But that does not mean all of those obstacles, all of those problems, to me, all said to me 6 years ago, wow, I love an industry with a whole lot of problems and a whole lot of issues, because that means there's business opportunity to build companies. And so there's tremendous opportunity in this industry. You as entrepreneurs have to focus yourself. You have to focus on which one of the three entities are you going to care about the most. And the three entities are providers, payers, and patients. Okay? Patients aren't going to pay you. They're going to love you. They're not going to pay you, right? Providers will pay you a lot of money if they're large hospitals. If they're not, if they're one of the other 700,000 medical facilities in the US, they don't really understand IT. And the other side of the providers is what we call, this is another crazy thing in the industry, acute care. Acute care is the industry's term for hospitals. If you're not a hospital, you're ambulatory care, which most people would think would mean a hospital. It doesn't. It means not a hospital. It means that you can walk. You're ambulatory. So in the industry, those hospitals have the money in IT. They spend 95% of the $85 billion that's spent in the industry for IT. They just aren't getting any value out of it. Okay. So my point to you guys is to say, when you ask me questions, when we talk in the dialogue here, I'm focused as an entrepreneur on how to attack this industry and change it. I'm deep inside of it. When you talk about data integration, I am down on a daily basis at the levels of, what individualized data elements can we map out of a database to something else, right? So when I say deep in the bowels, I mean, we're down in the nitty gritty of IT. But we also play and deal at a fairly high level within the industry, because the problem that we solve crosses so many different organizations. So it's a difficult problem we're tackling, we're one of multiple companies that are trying to attack this. There's the old guard and the new guard. Almost every company that's gone after this has failed. We won't, but everybody else should. Right? Being a good entrepreneur, Kevin. Everybody else should fail but us. But it's,
no, in this context,
and it's an exciting place to play because there is a lot of opportunity where there is a lot of waste and a lot of conflict and a lot of issues and difficult problems to solve. So I'll leave it at that, and we can.
Wait, no, let me respond to that one thing. The thing that I think that that the come from for our community, especially, I see at least 10 different startups that are or entrepreneurs that are represented here from the healthcare space, that like in the corpus of people that are in the live show. And then we have on Facebook right now, we have a bunch of different people that are saying, hey, I can't make it right now, but I want to be there. There's a lot of people who want a piece of this puzzle, right? And they want to bite into it for whatever reason. The key thing about it is, I think this is where this conversation about organizing together, I'm going to keep on echoing that over and over and over, because individually, as individual companies, I think a lot of individual companies have failed because they're, you're bouncing off of a market that it's resistant to change. It's healthcare. It's like healthcare, government, there's only a handful of things that are extremely resistant to change. And this is one of them. There are a couple of things that were said in the chat that I think are worthy of echoing.
Okay.
So I'm going to do that first. And then I'd like to open it up to different questions from people. I usually have a few questions myself, but since we have, and I'm going to allow us today to go over, since this is such an important conversation, I know sometimes people have to leave at a certain time. I'm going to allow us to go over our normal time frames. So just be aware that's probably going to happen with today's conversation because it's so important. Richard Hurley says, two unavoidable statistics: 50% of US healthcare budget is spent in the last 10 days of a patient's life, and more concerning, 80% of the USA healthcare budget is spent on diabetes, heart disease, and blood pressure. Yep. David Nichols is saying, interesting reading about, it's from the National Institute of Health. And we'll make sure that the chat session is copied into the show notes as well for those of you all that are watching this as a YouTube video. The gap in health administrative spending between the United States and Canada is large and widening, and it apparently reflects the inefficiencies of the U.S. private insurance-based multiplayer system. The prices that the U.S. medical providers charge incorporate a hidden surcharge to cover their costly administration burden. He said that he read elsewhere that it's like admin costs are 5x higher in the US than in Canada. And it kind of lines up with the way that I hear, at least in my listening, with what Randy's saying, is that, there's almost this resistance to innovation through technology change. And so they're throwing more bodies at it, more admin at it, right? Paulina said, an international question of food for thought, the countries that have free healthcare, nothing is for free. Consider the taxes that these countries charge. The public does get the help that they need, but hence the tax rates are much higher. Omar Zaki, one of our venture partners in Tech Ranch, who comes from a tech ranch. He comes from a telehealth background. Just announced that the University of Texas is setting up a shop in Egypt. And this points, I read a little bit about the article. I snuck looking at it really quick. Part of what that collaboration points to is the same reason that we think it's important that, U.S. healthcare problems are going to get solved by, Vladimir in Honduras. And they're not going to get solved by someone here in town. They're going to get solved elsewhere. And you guys are going to blow that technology back into town. Or Carlos, as an example, Carlos Bernal, based out of Chihuahua, Mexico, has this test for diabetes. It's amazing. It's now going to be installed in a bunch of hospital bathrooms in Italy. Really amazing technology that, and he also can tell you, you're about to have a heart attack 8 hours before it happens, so you don't have to have that heart attack, right? Kind of that's where this innovation is coming from. De La Herrera says, defensive medicine. Some countries have no-fault malpractice systems in which the equivalent of malpractice insurance is state-sponsored. Doctors pay into a central fund, and when a patient gets wow, that's a big word, iatrogenic injury, and the burden of proof is iotrotic injury, not gross negligence, in ordering the standard of care, the patient gets the claim paid, not a multi-million-dollar suit or anything, but we remember that in the US, we make the patients pay for their own remediation of iatrogenic injury because the doctor doesn't have to admit they did something terribly wrong in order for the patient to file their claim. The doctor often helps the patient fill out the medical error claim. What I hear in that is the doctor and, something happens and the doctor and the patient line up together to solve the underlying health issue because they're not put in opposition of each other. Okay, I really like all of the different things that are being said. I want to open this up, whether you're typing more in the chat or you'd actually like to say something. If you have a question to either one of our speakers, please ask it. If you have a statement, feel free to say it. The way to do this is bring yourself off of mute. And if you want to say it live, or you can just chat. Let's see, Kim Johnson just posted the question. Kim, do you want to ask that directly or go right ahead?
So we are up here in Washington State, we deal with the addiction related technology for infants and for people with alcohol. And so we're following the situation in California with Dynamic Care, which has tons of lobbying money to try to implement contingency management, which is basically payment for outcomes. It's a form of value-based care. So the answer is, as a small company, do I track as from the policy standpoint, from the player standpoint? Randall, both of you, is like, where should an entrepreneur look for this type of innovation? I don't. The national thing is the national thing. That's going to take a long, long time. We need to eat tomorrow. We get NIH funding and we develop that type of stuff. But who's more likely to really accept a risk-based approach to healthcare? And in Washington, I think we deal with Providence, who's just a bureaucratic mess, and we deal with a company called Multicare, which is, if the local president likes it, he'll get it done. So, I'm looking for, do you see any opportunities in the policy landscape for people that are really trying to drive solutions for us generally? I present mine as a case study of something that's kind of weird, right? But generally for us, who do you push against as an entrepreneur?
I'd like to hear from both Lauren and Randy about that. Who'd like to go first, Lauren or Randy?
I can just say a comment. I don't know, again, I'm not from the business world as much, so I don't know about entrepreneurial activities, but just with my consulting work I've been doing with healthcare companies that are applying for renewing their state Medicaid contracts. Medicaid is a state federal partnership and it's different for every state. So it's interesting that the Medicaid, and the big Medicaid RFPs that states are putting out, they're really pushing for that value-based care. So just because it's state money ultimately paying for people's health care, that a lot of the big proposals I've helped write lately have a value-based care component. And on my next slide, I didn't get to, I mentioned that as one of the smaller reforms, like Medicare has the ACOs that they're doing, but in Medicaid is also starting to push that. There's I forgot what they call it, like the up down, where both a provider could be at risk, could get rewards if they do offer better or more coordinated care than usual, or they could have a downside where they're penalized. But a lot of the things start out with just rewards without the possibility, of where they're at risk of penalties also. But I think things are everywhere going to start going toward that, because we need just that coordinated team-based approach, and not, just fee for service. The more you bill, the more you make. That's just getting our system into trouble. It's not sustainable.
Thanks. That was great. So the answer is Medicare and the ACOs. That, from your perspective, from a policy standpoint, is driven by Medicare. There's movement at Medicare and the ACOs that deal with Medicare.
Yeah, and Medicaid. From the state perspective, Medicaid too, because Medicare is just federal, but the state Medicaid programs are starting to really ask for the healthcare companies competing for the state Medicaid contracts to offer value-based care for their providers too.
So from an entrepreneur perspective, first, I think value-based care is a silly concept, and it's comical on its surface and below the surface. Value-based care is a real simple message in any industry. Let's drive down to the cheapest, crappiest service we can provide someone, and we'll become Walmart, right? That's what value-based care means. The obstacle you face, Kim, is in the healthcare business, they're very young in their understanding of normalized business concepts, right? Even very basic concepts such as revenue and cost are very, very difficult in the healthcare for them internally to determine. We complain a lot from the outside that, oh, they don't, their costs are too high, but they don't even know what their costs are. They can't tell you their costs at a microscopic level, and they can't manage them at that. So your challenge as an entrepreneur is, how do you take your solution to entities, right? Organizations, whether they be providers or payers, and hit them with, how do I show you how my solution either saves money or makes money? Because those are the two things you usually apply tech to, right? When you go to a business, you apply tech to either saving money or making money. That's how we sell this stuff, right? I'm not saying we always deliver, but I am saying that's the pitch we've made for 40 years as an industry. The problem you have is that if you go to them and try to say that, they don't actually know how to apply that internally. So what you really have to do as an entrepreneur is kind of walk them through where their problem is without telling them that's the problem, right? And it's challenging. It's difficult. It's very nuanced within the industry, and it's hard. I would say when you have a solution like that, trying to take it to the bigger organizations, the obstacle you're going to have, especially when you're talking about state type groups or federal groups, is they're the slowest to move. Your sales cycle is 3 to 5 years, same as it is for a hospital. Now, if you can tweak your solution to be focused more upon the payers, the real payers, not the Medicare, Medicaid guys, which represent 63% of all payments, but those guys just funnel money. They don't actually manage it. They don't have a problem, right? They just spend it. I'm talking about the Blue Cross guys, the guys that are spending money as insurance, the Aetnas, the people that are putting the Optums, or I guess they're United Health, that are insuring the organizations. If you can focus on them, or you can focus on to entities that really are impacted by the money, those entities understand where your solution will solve a problem for them, and they'll get it rapidly and they'll move rapidly.
Yeah, that's what's interesting. And I've actually mentioned to I see two of our entrepreneurs from Mexico that are in the healthcare space as an example, and I've been like, hey, Carlos, I want to be able to walk into a Target, and I want to be able to reach up onto the shelf and buy the little device that I take home that costs $16. That the engineering came out of Chihuahua, Mexico. I'd love to hear from David Potes and Carlos Bernal. You're both used to me putting you on the spot. So usually I only put one in you on the spot at the time. But since you come from a different perspective, would both of you hop in for a second and say, hey, this is how you're doing stuff in Mexico, and you can give kind of a thumbnail sketch of what you're up to? David, go right ahead.
Thanks, Kevin. Sure. I mean, it's a really interesting subject, and I was really interested in learning more about the deep inside what's happening with the healthcare policies in the U.S. Here in Mexico, it's really complicated to try to explain it quickly. It's a really disintegrated system. It's multi-payer, multi-provider. And I do see a lot of coincidence, and I was really interested in what Lauren was explaining about where could solutions be found. Actually, one of the things that I was going to ask Lauren was, I saw that you mentioned that one of the reasons that there are higher costs in healthcare was the providers in general, talking about pharmaceutical hospitals, physicians in general. Do you know if there's a reason why that is? Is it because of the administrative costs, or is it just? I understand there are no controlling costs right now, or well, there's some type of controlling costs, but there's not in general a policy for that. And second question related to that, does it have to do with the information exchange between payers and providers. Because just to give you a quick parenthesis, that is what is happening here in Mexico. In Mexico, what happened was that payers said that they were going to pay for provide the payment for the treatment, and hospitals saw that as a blank check, right? So the prices went up, and at the end, who ends up paying for this is the patient, right? And then everything started to move. The co-pays are pretty high, the deductibles are really high, so that you can actually pay for insurance, but at the end you cannot use it because the deductible is so high. So I was wondering if it has something to do with that. And this is related because what we're working right now is with the Mexican Hospital Consortium, that is a group of 52 hospitals. They actually gathered together and exchange information, and this also relates to because of what Randall was talking about, and how to consolidate that information and actually open that to insurers and say, we're small, medium hospitals here in Mexico, this is our costs, and this is how the insurance that will work with a closed network actually operate. I don't know if that was too much information, but I don't know if I explained myself.
I think so perfectly. The most important thing that I want to make sure that I wish we could go into much more depth, and I want to make sure that I mention this about David's company. I think he just mentioned as an example, it used to be 49. It sounds like it's now 52 different companies, different hospitals that their product is integrated in with, and it's a different way of looking at. David's company is also in the process of coming to the US as well, and we're privately exploring a different entry vehicle for his company into the US and others. And so the main thing about it is since I used to play Stratego and the game Risk a little bit too much, sometimes you look to your adjacent countries about how you can actually invade a market. Maybe that's the high school version of me who's thinks about that a little bit too much, but it's interesting because of what David's done. Carlos, since you're here as well, give us a high level perspective. You just went from Mexico to the US to Italy, and just give us a thumbnail sketch of what your product does, and then what's happening in Mexico, what's happening in Texas, or US, what's happening in Italy for you, and what's your perspective about this?
Okay. First of all, thanks for all the information. I mean, for me, we've been looking at the U.S. healthcare system for the past 5 years or so, and it's to be honest, it's quite complicated. It's getting complicated in Mexico as well. We created a technology that measures different metabolites in urine. And we now can measure things like glucose, ketones, proteins, different proteins, blood, and things like that. So we've been playing around while developing the technology. We've been playing around trying to find a way to actually access a market. And what we have found so far is it's kind of, that's their personal belief. It feels like it's the kind of a product that is going to help a patient, but it needs to be recommended by a doctor. And in the case of the United States, it's like, how do you approach a doctor or a citizen of a payer or the government? Like, we don't know exactly who we should approach, or it looks easier in Mexico. We're working with the first B2B client, and we're already signed a first contract, but they're always exploring what could be the way to actually address the US market or try to enter there.
So Kevin, I think that speaks to what we've been talking about, right? Is in America, your challenge is you got to find the people that are willing to pay to take a risk on a new technology early and fast. And you have to kind of look beyond the big industry, because the industry is massive, right? At $4 trillion. I mean, it's just huge, right? But you've got to look at, where can I as a young company go and get some traction fast, right? And that tends to not be in the places you'd normally think. Government's challenging Large hospital systems, for-profit or non-for-profit, it doesn't matter because they're split evenly, basically, that half the hospitals in the US are non-profit and half are for-profit. But the hospitals don't have a tendency to put a lot of money into innovation. They have a tendency to put a lot of money into innovation centers. But you need it deployed in the field for you to get traction. And the way to do that is to get outside of that and to focus on who has that pain. Who is it costing money so much so that they would be willing to spend money to try and solve that problem? And sometimes that's the payers. Sometimes it's just the providers, right? If you have a provider, for example, that's involved in what you're doing with the Carlos, with glucose monitoring, right? The provider themselves may not be getting compensated enough by the insurers to spend a lot of time on that, but they know that they need to solve that because that's how they can help the patient. Going to them and showing them that then says to them, oh, well, hell, I'll spend a few grand to do that, you know, because it'll help my outcomes. It'll help my patients. And I'm not going to get the money out of Medicare, and I'm not going to get the money out of United, but it saves me money as my business because now I'm better at getting better outcomes out of my patients. It's just hard to find that. It's really, you really got to focus upon that. And I think that's what you're saying is that's the hard part, is figuring out where do you go to get the fastest bang, because you can't survive for 10 years waiting for it to happen.
Well, let me insert a commercial at this point on something that's happening that I don't have anything I can announce yet. But one of the things I'm convinced over and over and over that this idea of getting a bunch of piranha taking on the sharks and the whales of the world is the way to move forward. And yesterday we had, it's not ready to announce yet, but we had in the mental health special interest group that y'all know that I'm driving. Someone just bought in big, and I won't believe it until the check's in the bank, but someone just bought in big to this idea about how we set up, a piranha-based network of mental health solutions. That's over here in the mental health special interest group. There's a project that TechCrunch and the University of Texas, the ATI, and a group called the Texas Global Health Security Initiative originally was focused around virus therapeutics and stuff like that for the pandemic. But, I raised my hand and said, hey, I really think there should be a mental health special interest group as well. All right, so that's moving forward over here. We have a similar project that I've mentioned in the past and we've done during the Venture Outfitter Weekly called the Patient Care Innovation Bridge. Patient Care Innovation Bridge. And we actually saw collaborations. They're light collaborations, but collaborations that happen between Texas, Mexico, Italy, and Egypt. If Omar Azaki, our venture partner that's focused on Egypt, he's Egyptian American. He had to go ahead and sign off a little bit ago, but I probably put him on the spot right now for two different reasons. One of them is he's the lead on the Patient Care Innovation Bridge. He's also the lead on the Egyptian Egypt-Texas bridge that we're working on as well, right? Which is why that news that I mentioned earlier was in there. Part of what I'd like to make sure that I'm pointing to, and as we're talking about it now, individual startups, I don't think can actually really, I've seen you guys beating your heads against the wall. The wall happens to be a hospital or some other type of place, and finding that entry point is difficult. Part of the way that we want to organize is to organize in these innovation bridge type of activities. Now, a lot of the way that we're funding that is, I'm going to countries and I'm saying, hey, give us your best and brightest in the following area, and let's see what we can do. And, like as an example, David and Carlos that we heard from today came from a program, an innovation bridge that was funded by the federal government of Mexico. And we got to actually find some of the best and brightest, most compelling solutions there that then we can bring together to take on these different markets and learn faster together. We'll be doing that. I've been excited. I've been talking to Randy about this for a long time. I just hadn't brought him into the conversation now, but I'm totally, you can already tell by his personality. he's the kind of obstinate type of person that's going to keep on running against the wall until the wall, concedes and falls down. Lauren gives us a little bit more of the nuance, the depth, the research, the background, so we can find those soft spots to take things on. Because we're beyond the normal time frame that we have for this program, what I want to do is I want to make sure that we capture everyone that's here that's interested in this conversation and have another VO Weekly where we go more in depth on this. Part of what I'd like to propose is to make sure that out of today's program, there's probably 3 or 4 or 5 or whatever questions that you'd like to see us organize around. And instead of it coming out of my brain, right? Randy and Lauren both asked me, they said, hey, well, what do you want me to talk about? I want to flip that on end. Like, I'm just the guy who's in the rear guard, trying to make sure I get some other resources for all of you entrepreneurs. The thing that I'd like to do is I'd like to flip it around, that a common conversation on the VO Weekly, as well as the thing that drives the funding that we go get for the Patient Care Innovation Bridge, that we actually have what you think the next conversation should be. Patient Care Innovation Bridge, this healthcare issue, it's not going to go away anytime soon. There is a point of entry for the entrepreneurs that are outside of the US to come to the US. There's even guys like right now we have Lagos, Nigeria represented here as well. And part of the way that we flip this picture, right, is we actually look at how sometimes we might not be able to innovate here because of regulation, but we can figure out how to innovate someplace else in the world, get it to a solid ground, and then bring it back as well, right? Like, you get the venture to a certain solid ground on a specific technology or concern area, and then not lock it back. Carlos's company is a great example of this, coming up with a different way of looking at metabolites and a different set of electronics for that than to go figure this out. So I see a bunch of different things coming back to me about it. I see some evidence that you guys are already connecting. Kelly says that she's connecting with Carlos, and there's some interesting stuff that happens. By the way, as you guys collaborate, one of the most important things for the storyteller at the head of the story that's being told, make sure you keep me involved in the story, me personally involved in the story. Yeah, I am overwhelmed with the amount of email that I'm getting, but the truth is it's telling these stories that actually allows me personally to knock down doors for y'all to then get more resources there. That's how we're going to play this game. So Lauren says that she's going to send a few thoughts to me to forward to David and Carlos, and I'll make sure that we do that. Part of this conversation as well, we have a Slack channel that hasn't been very active concerning patient care innovation. I have 2 groups of facilities, senior care facilities, one of them that has 25 facilities, one of them that has 30 facilities, that at some previous time I talked into building skunk works around. So that might be one of the places where there's a lot of pain. There certainly was during COVID times. They got overwhelmed by the pain, but it's possible that as you look at these type of things, I can pull those type of people in, because like the guy that's in charge of that 25 facility place, he ended up getting overwhelmed by what happened with COVID during the last year and a half, overwhelmed from the standpoint of they had a lot of deaths that happened at those facilities, those 25 facilities. But this is the sort of stuff, your stories, plus some of the network that I and the venture partners at Tech Ranch have, we can knock down these walls together and do it that way. Any closing words, Lauren or Randy?
Go forth and conquer.
Certainly.
There's nothing but money out there.
Yeah, we know, and that's partially what we're here for. So I'll just switch back into closing up with the program. Tech Ranch is going to be in these countries. I will be in Budapest, Hungary next week. I got asked a while ago in the back channel if we're going to have next Thursday is Thanksgiving in the United States. but I'm not going to be in the United States. So I will be celebrating Thanksgiving in Budapest, but we will have a VO Weekly. And so those of y'all that are not in America, like those of y'all that are in the United States that are going to be having turkey or tamales or whatever you do, we're going to miss you. But next week we will have an interaction. I'm going to be a little bit more focused around some of the activities that I'll give you kind of a Budapest report, and I'm going to try to pull a couple different people in to more of a Oprah style conversation in front of you, from Budapest to kind of give you the results of what happened. Just so those of you that don't know, the Hungarian government invested in a venture bridge invested in the Texas-Hungary venture bridge. And this is the activities that we'll be doing in country during this week for that first part. We'll be in Brno, Czech Republic on January 24th, or that week. I'm going to make sure as well, since we've had the Czech Republic, I'm going to drop by Prague as well. And probably during that trip, since we have a little bit more planning time, they're more than likely several of the countries right around that, because I'm convinced that part of what we want to do is to gain access to the Central European insight. There's some brilliant technologists, amazing science that's happening there. Like as an example, just to throw in something about Hungary. Do you know that the doctor who actually discovered some of the most interesting work around the mRNA process, the process that's been used for some of the vaccines, is actually from Hungary, as an example. And one of my favorite authors about flow, Csikszentmihalyi, I never can say his name. He just recently passed away, but he's from Hungary. One of the world's top experts on trauma, Dr. Gabor Mate, is Hungarian. So that's just a commercial about Hungary, but the truth is that all of Central Europe, there's a lot of interesting stuff that's happening there. We'll make sure that we actually bring that into the fold as well. And there will be several other places. These are confirmed, but for right now, there's some other stuff that's happening. If you're not involved in if you want to get on our country manager list, if you want to get on our mentor list in a more formal way, if you want to get on our newsletter, if you want to connect to our social media, all that sort of stuff, we have one clearinghouse page on the website just to make it easy to engage. For those of you all that are here, I want to make sure that Jello, my assistant, is going to make sure that we all invite you into the healthcare, the Patient Care Innovation Bridge Slack channel. I also want to make sure that you're in the Venture Outfitter Slack channel so you can be involved at whatever level you want to be going forward on that. He'll do that. He'll collect the email addresses that were used to log into this today and add you into that Slack channel. If we miss anything, his email address is ea@techranchaustin.com. That stands for Executive Assistant at techranchaustin.com. And but more generally, make sure that you're connected in, because a lot of times we are starting to really aggressively do newsletters and other media. We're learning how to do that right now. The truth is that we've got a lot to learn about how to do it even better. But I want to make sure that that we get a chance to do this. And then with that, thank you again to DualWorks. I've already heard all the noise right outside the door. I'm not sure if it made the recording. The Thanksgiving party is today, so I'm going to have myself some pumpkin pie and interact with a lot of the people here. And like, if you are looking for a point of presence here, let us know, and we'll connect you in. And with that, we'll bring things to a close. I'm always honored to get to work with entrepreneurs that are driven by vision and values. And I'm excited to actually have this conversation, because I can already tell, based on what you all told me, that a couple of connections happened in the back channel, in the chat session. Let's take that to the next level. We'll invite you into the Slack channel so that you can actually interact a little bit more. I'll make sure that Omar follows up with more details about what's happening with the Patient Care Innovation Bridge, because our intent is to open up this decentralized innovation, so it's not just one company going after things. Kim Johnson, who we heard from earlier, has been really successful, as an example, going after small business innovative research grants. But more generally, we'll look at how we can get more involvement from another way of driving innovation together that you can take advantage of. And with that, we'll call it close. So thank you all for your time today, and look forward to hearing about the follow-ups. Thanks to all our speakers. Thank you, Lauren. Thank you, Randall. I appreciate y'all working out, especially as I was like, hey, I think y'all have an interesting perspective. You also provide some different points of view that really help us drive dialogue. So with that, we'll be back in contact again soon. Thank you. And Jello, stop the recording.